We have a pretty short slide deck actually for you folks today because I know I know one of the desires or at each presentation there were a number of questions that had arose. So we wanted to make sure that today was focused on demonstrating some examples of cases that we've gone through the clinic and we've seen, so that way you kind of have a bit more of a real world experience, but also provide ample time for discussion and questions. So, as much curiosity that is expressed, we can budget time for.
All right.
Thank you, Dr. Patel. Hi, everyone.
Thank you, guys.
So without further ado, I'll go ahead and kick things off with, so today's focus is on kind of third part, kind of the capstone to the series of basically managing complex psychiatric presentations with an airway approach. And what we found, Dr. Shipley and I working together with physicians here at Kahala Clinic, is that it tends to be quite substantial outcomes we found, and we want to just present a few cases after talking about in previous lectures the evidence for it, and also kind of the methodological approach at kind of evaluating a patient and looking at treatment options. So today we're going to present 4 case studies, and then we're going to budget time for some discussion. So case 1, this is a case of a 16-year-old female to male presents with for a gender dysphoria rule out. They were referred by the PCP as the individual was looking for gender transforming interventions with hormonal therapies. And but at the same time, the PCP had recognized the individual had a significant amount of anxiety and concerns with a number of their behaviors, along with their mood. And so they had been forwarded to our clinic, and this was actually while I was in training at Kapiolani Behavioral Health Services. And at the time, I had the chance to get to know both the patient and the family for over the course of 1 year. And it turned out that the child scored substantially with symptoms of generalized anxiety, fear of going to school, about 2 days a week on average were being missed, as they would just have kind of these intense bouts and not want to head out. As a result of falling behind in school, they would fall behind on their homework. And on the surface, it looked like a case of just kind of really bad anxiety and this behavioral phenomenon, and just kind of needing support with going to class. And if they were to have that support, then over time, they'd kind of desensitize from attending school. But what was really profound was just their persistent fatigue. And when talking to this kid, I remember they would tell me just how they had been experimenting with sleep schedules because they couldn't sleep through the night, and it would take them over an hour to fall asleep. Sometimes they would wake up, usually for several hours, and then they go back to sleep. And they had even switched to, they'd been reading online about different sleep patterns. Like I believe there was like a 4-2-4 sleep pattern where they sleep for a 4-hour nap when they came home after school, and then 2 hours late at night. And then they would have another 4-hour rest right before school started. And so they'd kind of carry out their work through the middle of the night. So, suffice to say, they had a completely disorganized sleep schedule, but they found that this was the only way where they could feel refreshed during the periods, or refreshed as possible during the periods in between their napping. And so one of the things that kind of stood out to me was, despite their prominent symptoms, I noticed that they had actually rather a small jaw. They were obese, and they had bags under their eyes, indicative to me that possibly having allergies. And so what that would be concerning about is that whatever nasal passage space that they did have would be obstructed by mucus constantly draining down into that space, possibly. And what's known as a head forward posture. So just to kind of exemplify, looking at me from a side profile, we'll notice someone with a head forward posture tends to kind of sit forward more like this, or maybe they usually have hunched shoulders as well. And the potential benefit of that is that when you have a small jaw, actually what it does is it actually kind of opens up the airway a little, but it's very challenging what it's indicating is that the individual is usually trying to mouth breathe at that point, and so they're not breathing through their nose. And upon physical exam, I also noticed that when they opened up their mouth, the roof of the mouth, it had what was called a vaulted palate, or it was rather high. So rather than having a typical appearance as such, let's say if I looked at it, rather what you see is you see it kind of pop up in the center. And remember, the roof of the mouth is the floor of the nose. So if they have a high ceiling, that means they have high floors in their nose, so their nasal passage is being obstructed, which is the only route through which a person is supposed to effectively breathe through. And so when I looked through the oropharynx as well, I had difficulty visualizing it, as they had a narrow airway. And so that was one thing that was indicative that this individual was probably predisposed to having a small airway to begin with. They had craniofacial features of having a further narrowed airway passage, and they also had they were overweight, so it's likely that they had fat pads that were rather enlarged in the airway that was further narrowing it down. And then so when a sleep study was performed, it turned out that they had an AHI, or apnea hypopnea index. So on average, they were not breathing 12 times each hour, or they were breathing at a reduced rate to the point that they were desaturating quite significantly. And however, during REM sleep, which, to remind you, is the period at which the brain recovers the brain, and you can think of as non-REM sleep as just roughly as the period where the brain is focused on recovering the body, they were not breathing 13 times every hour. And they had awoken 35 times, or microarousals as they're known as, meaning we wouldn't have identified it if we were in the room just sitting on a couch beside them, but their brain had just woken up for a brief short period, sufficiently to have fractured the sleep. And so the child refused an SSRI along with their parent. What was initially is what was offered when when a teenage comes in with severe anxiety that's causing severe functional impairments for them. Hydroxyzine was offered, and they'd only taken it a handful of times. They never even got a refill on the prescription. And anemia was identified, and so they were started on iron therapy. And then auto CPAP was initiated. And by the time they had the CPAP, it was a dramatic change. They began feeling refreshed with sleep each day, and the napping had reduced, and more of the sleep had consolidated into a single phase at night, which is significant because it's the last hours of sleep that you need at night. So let's say your brain needs 10 hours of sleep because you're a 14-year-old. It's hours 7 to 10 where the most REM sleep take place, not hours 1 through 4. So taking 3 4-hour naps is not equivalent to having 1 10-hour night of continuous rest. And so subsequently, the inattention improved as the child was convinced that they had ADHD, when in fact they did not after they started sleeping well. Homework was completed on time now because they were operating efficiently. They were getting the work done in school. There was very little to complete at home. So they improved. The avoidance resolved with school. The school performance improved. And then throughout the entire process of getting to know them for over a year and a half, there was no evidence of them actually having any sort of dysphoria regarding the gender transition event. And that became much clearer, especially when their psychological symptoms had really kind of melted away. So the second case is a case that was initiated. The care was initiated by Dr. Shipley. And
Dr. Patel. I wonder if it might be helpful just to keep it in our minds to go case by case, up to the audience, but so we don't. There's a lot of good information in each one. So.
Yeah. Anybody have questions or comments on that first case?
Oh, I see what you're saying. Okay, sure.
What is auto CPAP?
Yeah, good question. It has multiple names: auto CPAP, auto PAP, APAP. And essentially the difference between auto CPAP or regular typical CPAP is that typical CPAP with the amount of pressure that's provided to the patient or individual is defined in a lab. And so they will go there for usually a follow-up sleep study, or sometimes it takes place the same night, and they identify what pressure on this machine has to be blown into the patient in order to splint their airway open. Auto CPAP forgoes that step. And so what you do is the CPAP machine itself is given a range in which to operate within. And every breath that the individual takes, the machine measures what the resistance is and determines how much pressure is required for the next breath. And so it tends to be a much more, you could say, tailored approach for, let's say, average individuals suffering from sleep apnea.
So that sounds much better. Is it more expensive or anything?
It's become the industry standard because of the substantial benefit that it provides over typical CPAP. So I really haven't seen any individuals being prescribed CPAP actually.
Yeah,
And
and additionally, I think from a clinical practical standpoint, CPAP requires an in-lab titration, which depending on the level of severity of AHI that was detected in the sleep study, they may or may not do the titration in the same night. So a lot of people don't want to go to a lab for a second time. And so APAP, as long as we write it in our note that they refused or do not want to do in-lab titration, then that usually gets covered for APAP. So then they just go pick it up, get their mask fitted, and then the journey of getting used to it at home begins. Yeah.
I didn't even know that was available. So that's wonderful, because the hassle of somebody going to have their CPAP machine checked all the time seems like a deterrent to me. So this sounds way better, especially for a teenager.
It is. It's questionable if you know, in terms of whether the cost difference is actually that significant, because it's probably on the orders of hundreds of dollars. Mind you, because every time you have to go in for a titration, the copays on it can be quite significant as well.
Yeah, I think from a cost perspective, they're pretty equivalent. One thing that we've run into is if for people under 18, the insurance companies oftentimes want an ENT evaluation and intervention before starting a CPAP or an APAP, but a lot of times you can indicate that the clinical symptoms, you know, because there's a long wait time to see an ENT, and then even further wait time until there's an intervention in place. In the meantime, as a short-term option, the family would like to start APAP. And for adults, you can make the same argument as well. For adults, they're much quicker to start a CPAP or an APAP.
Oh, so somebody asked me what I said. I was asking him what an auto CPAP is, because I didn't know there was a CPAP that self-regulated based on your breath. I thought you had to have this. I'm old school. I thought you had to have it set and stuff. Dr. Weir asked how obese was the patient, and then I'll add to that, did she lose any weight in this process?
Yeah, good question. There was at the time of the sleep study, the patient had a BMI, I believe, that was 37 or 38. So it was rather high. And in terms of losing weight after they started CPAP, so they have begun, I haven't tracked their weight specifically, as my focus with the patient was on their psychological symptoms and providing an evaluation for to see if they had a consistent position on the gender transition. I believe it was the PCP who was following for obesity. But what I do know changed is that while working with them, they did try exercising on a regular basis, and the amount of effort and the frequency of exercise substantially increased once they began using the CPAP regularly.
Well, that's nice.
Yeah, and before we, rather than waiting for one of my slides to comment on the obesity part, I think for adult practitioners or practitioners who see adults, we commonly associate, and just in general, kind of society's messages, you know, obstructive sleep apnea, obesity, lose weight, obstructive sleep apnea goes away. At least when I started working with kids, and now I kind of look back at my adult training and think, how many skinny adults have sleep apnea? One of my cases coming up was a very, very skinny young girl with very severe neuropsychiatric symptoms that got better with airway management, and she was found to have moderate obstructive sleep apnea. So I think that there's a bigger picture kind of idea here, and looking at the neuropsychiatric phenomenon as symptoms that may indicate an underlying sleep or airway issue, I think is actually a more sensitive test than obesity.
Mhm.
Yeah.
Yeah, very much so. There's and as and this is one reason why we included a bullet point regarding physical findings, i.e. airway clues, because we want individuals, providers, caregivers, family members to think beyond just weight, because that was certainly, I would say, probably the easiest way to raise awareness about sleep apnea, about one of its kind of common associations, but to just know that it goes beyond that. And that's merely one impinging factor. And to keep in mind that oftentimes I've heard of obese kids receive recommendations to go exercise and then their sleep apnea gets better, but I don't know for sure. I don't have any data to back this up if there's like a tipping point or something, but it's really hard to go and exercise when you're tired all the time. It's really hard to regulate your appetite when you're craving because you can't get restorative sleep all the time.
Mhm.
And so it might actually be that, in order to it might actually be putting the cart before the horse to try and, mandate a plan. If a kid especially doesn't have a history of being regularly active or not engaged in a sport, and there's no clear, structure around some sort of dietary program that's likely to be executed with the child, that'll be done so faithfully at home.
Right. And I think in general, and we'll kind of see this more and more as these cases go on, particularly in our field. I think in psychiatry, we see patients for such a long time, and sometimes for 45 minutes a week, and we're kind of used to this clinical sequence and longitudinal kind of clinical approach where these things are going to take a long time to get better. Obesity needs to be addressed. Multiple aspects of the airway needs to be addressed. Allergies leading to inflammation, leading to constricted nasal airway needs to be addressed. Maybe it's turbinates, maybe it's adenoids, maybe it's tonsils, maybe it's a large lower mandible or a small lower mandible or a high arch palate. There's over 20 potential points of constriction from out of the mouth and nose to the alveoli that could lead to poor oxygen delivery to the tissues. So all of this does need to be addressed. And when you're working with something that some folks are calling a super node of health, like oxygen management and sleep management, something that happens either 8 hours a day or 24 hours a day, if that's something that hasn't been treated for a long time, you're going to have a lot of downstream effects. It's going to be affecting the heart, the liver, the lungs, the brain especially. And so all of these aspects I think are really important to bring up, right? And to address and to understand that when you start to get into this space, treating these cases, the effects are large, but they take time. And there's a sequence of recovery in regards to where the what gets better at what point. So more food for thought. But
And Renata's commenting on that obesity is different from adipose tissue percentage and the ability for hemoglobin to link to the oxygen affinity. So there are many other things that come into play here.
absolutely, we see people with alpha thalassemia, Hawaii, sickle cell in New York City, where I did my training, and these are all aspects that need to be looked at as far as oxygen delivery to the brain.
Mm.
Great. Any more questions on the first case?
Okay, let's take it away to the next one. So I'll let Dr. Shipley kick this one off.
Yeah, so in this case, so we have a 12-year-old female to male, someone who I also saw in Capilani Behavioral Health when I was a fellow and continued to work with them in my private practice after graduation. So initially when I saw her, she was referred to herself as a female, and she was going through a lot of self-harm behavior, non-suicidal self-injury. The parents had some issues, but they were sorting that out. Very attentive parents, and I had no suspicion of direct trauma. Maybe some witness fighting, a little bit of therapizing your kid, but pretty standard things that we work through in family therapy, and things get better pretty quick. But she did also have these kind of neuropsychiatric symptoms like OCD, intense social phobia, which got worse during COVID. Common story that everyone hears about. I have some theories about why that is the case, but it got a lot worse during COVID, and she soon was not able to even go to Ala Moana with her friends, let alone going to back into the classroom. Mind you, this is a person who is thin, smart, physically active, like kind of beyond smart. I think her IQ was like tested around 155, and had a lot going for her. No bullying, and but just couldn't. This feeling would happen. This physiological arousal would happen when she thought about or approached school. Additionally, she had a history of absent seizures, and she also had pseudo seizures, non-epileptic seizures. I don't really like both of those names because diagnostically they're useless, because you shouldn't really call things what they aren't. I think it's better, more accurately called a dissociative attack. And that starts to allow us to get to a neurological substrate that's treatable. So that's an important thing to keep in mind. So she also had a lot of fatigue and kind of these pseudo trauma-like symptoms. A lot of people attribute dissociative phenomenon to trauma. So we're always kind of digging for that, but it seems like there's more to it than that. And she also had insomnia. So physical findings for her, she's slight, she's thin, and a lot of times what we see for thin people is also a thin internal nasal passage. She had bags under her eyes. There's kind of a debate about whether that's deoxygenated or pooled venous pooling, or difficulty with outflow of blood in that area, which is oftentimes more associated with allergies. Maybe it's a combination of both. Most things are. And also she had difficulty with nasal breathing. Her sleep study showed 4.6, REM AHI of 28, and awakenings of 28 awakenings that night. So she had some iron therapy for anemia that was kind of found incidentally, but to the hemoglobin point, right? It's important to make sure that the delivery system is in the blood is also up to par, not only the delivery system to the alveoli. She ended up having a turbinectomy, but before the turbinectomy, I should point out that she'd been struggling for a long time, difficulty with going to school, SSRIs maxed out, and OCD symptoms relatively not controlled, and social anxiety symptoms maybe went from a 10 to an 8. So still severe and debilitating. Prior to the turbinectomy, I did a little bit of, at that point, was a Hail Mary, but at this point I've been doing more in my clinical practice, was I ordered guanfacine. And the alpha agonists, I think, are underrated. And I remember one of my advisors in fellowship had found a paper talking about clonidine. Is it a panacea? Because it seems to help a lot of things. But there's something about the alpha agonists and sleep apnea. I'm still not sure what the pathophysiology is, but when we prescribe an alpha agonist at night, the downstream effects of the autonomic arousal secondary to oxygen desaturations in the blood seem to get better. Again, the downstream effects. Not that the oxygen desaturation gets any better, but the downstream effects of that. Because when the oxygen gets low, a survival response is initiated, and the brain goes, hey, I need oxygen. I need oxygen more than any part of the body. And if I don't exist, you don't matter. So the whole body goes into high alert. Cortisol gets released, sympathetic nervous system gets activated, and sleep architecture, restorative qualities of sleep get disrupted. And then downstream neuropsychiatric effects happen. For some reason, I ordered guanfacine, and lo and behold, the amount of dissociative attacks went down. And sleep got better, and the frequency of absent seizures also went down. So she started to be able to go to school again, because at that point she was going to school, social anxiety was a little bit better, she wasn't making any new friends, but at least she wasn't seizing all over the place. So she was able to go to school, she maintained there. Parents at that point thought, okay, well, we're in a holding pattern, let's wait for the turbinectomy. She gets the turbinectomy, she goes into recovery, and I see her a month and a half later, and she is a completely different person. I've never seen a more profound effect, except maybe putting a schizophrenic in their 30s back on their medications. That can be pretty profound too. But in this case, turbinectomy, And she went from 2 or 3 friends that she had a hard time being around to having over 16 friends. I'll never forget that number because she wrote down every single name. Again, smart girl. And she wrote down every single name. And not only did she write it down, but she was able to tell me in very astute, mature, with very astute, mature observations about her conversations, the depth of the conversations. Anxiety is a issue with approaching things, but even once you approach things, you need to be able to engage it. And that's why we talk about mindfulness. The power of mindfulness is that you engage with the moment. And that's when the beautiful transformation really starts to happen. When people can start to engage with their environment, engage with their loved ones, engage with their husband, their wife, their kids, their friends. That's when life starts to take off. So in this case, the turbinectomy did a lot more than what SSRIs tend to do. SSRIs help with the approach, but they don't really help with the whole picture. Now, I have my theories about why turbinectomies in particular are helpful for social anxiety, and they have to do with the fact that things or behaviors that require breathing while you're doing it, which is almost everything, if they also require your mouth and you can't breathe through your nose, what happens? Well, every time you talk and you can't breathe through your nose, you can't breathe anymore. When you're eating, if it's something that takes a lot of chewing and you don't learn how to chew with your mouth open, or your parents don't want you to for good reason, then, and you can't breathe through your nose, you also can't breathe. Enjoyment goes way down, heart rate goes up. People start to notice their heart rate, anxiety goes up too. So in this case, the effects were so profound, I had to figure out in my head, I had to come up with some sort of hypothesis for why this is the case. That's what I'm working with. So the turbinectomy happens, and at this point, pseudo-seizures go completely away. We come off of guanfacine, or at least we down titrated. Is this patient still on it, Dr. Patel? I think
The
they're
guanfacine, they're currently not on the guanfacine, no.
off the guanfacine now, which had initially, and the improvement sustained. No more pseudo-seizures. And now the absence seizures, I don't know, we recently transferred it to Dr. Patel, but last I checked in with them, the absence seizures also reduced to only happening once premenstrual, a month or a cycle. So there's still some work to do there. Last I checked in. OCD behaviors also improved, noticeable, but able to respond to exposure and response prevention therapy, which is basically you feel the urge to have this obsessive thought or have this compulsion, and you resist that urge. To the extent you can resist, the urge goes away. And so ERP became much more doable. And the suicidal ideation actually got better a long time prior with family therapy. So that was a profound case for me, thin girl, every reason to be fine, on paper. Parents are caring, they, she has a good relationship with her sister, is able to make friends, but something was off internally. And the fascinating thing to me is that it wasn't psychological. I mean, it was later, but at first it was physiological. And so once we fixed the physiology, then the psychology got better.
This is super cool. Yeah, this is super cool. I know that these are cases from years and years, but these are this is really amazing. Okay, Renata asked if there was birth trauma, like when she came out the vaginal canal.
Yeah. So birth trauma, some people have different definitions of it. Some people have more of a psychological definition, and other people have more of a physiological definition, like anoxia related to a nuchal umbilical cord.
And it's probably hard to get into that history.
Yeah, we can. Yeah, that'd be good for follow up. Maybe, yeah, Dr. Patel, you could ask them at follow up.
Yeah.
But that's a really good point, though, and that's something that at another clinic that we work with, that we asked about that. Any kind of brain injury, because kind of more theoretical here, but it's about brain networks. It all ends up being about brain networks, which is why MRIs and maybe diffusion tensor imaging can look at it, but that's really expensive and unusual to get. But MRIs and CTs just aren't going to pick this stuff up. which is okay. It's just not the modality yet. But when we start looking at the neuroelectrophysiology of it, we start to see the network inefficiencies or discrepancies from region to region or within region. And so the rate of firing from region to region seems to be the issue. And the beauty or the power of REM sleep, rapid eye movement, is that it helps with the networking of the brain. So
Did she get any EEGs? Did she ever have
yeah,
one?
had EEGs, but again, absence seizures. For the neurologist had EEGs, and they couldn't find anything during the recording time. Yeah.
So this is really interesting because on that first case, I was going to ask you if you repair the palate or the turbinates or the tonsils, does the sleep changes take care of a lot of this? And you just answered that.
Yeah.
Yeah, and in response to Renata's question, I was just pulling up the ancient P because I do ask developmental questions, and she was born preterm, or he was born preterm, nursed for 9 months to a year, no delays, walking, talking, speech, and then in terms of head injuries, as a little kid, age 3 or 4, I believe, there was one that they could recall where they hit their head on the playground, on the forehead. There was a great big hematoma.
Interesting.
That was years prior to the presentation.
Yeah, and what we found is that for individuals who, some people recover well from concussions and some people don't. And concussions, we're starting to kind of use to use that term more. We have a lower threshold for what that means. And I want to just point out, so things on this slide that really stand out for me is first and foremost that REM AHI. That REM AHI, that's where the money's at. Non-REM, think about it as bringing construction materials to the construction site, but that's only as great as the house that you can build with it. And there during REM AHI, during REM sleep, that's when the house gets built. Non-REM, energy, building up resources. And then the body says, hey, everyone chill, everyone stop what they're doing, except the diaphragm and the extraocular muscles, which is a pretty profound thing to do. If you think about evolution, natural selection, it's probably the dumbest thing you could ever do to somebody, is to completely paralyze them for a third of their life. But it's that important from a survival standpoint. It makes the daytime that much more productive. So the REM AHI is something that we look at all the time. So I found that actually has a better correlation with emotion dysregulation and not as much OCD. I don't know, that's a weird thing. I don't know if you've noticed that, Dr. Patel, but emotion regulation in particular. So in the adult world, people talk about borderline, right? I don't really like that term anymore because it's not very physiological. But what we found is that every single person that would meet criteria for borderline personality disorder, they have underlying airway issues. And a lot of them are thin.
Wow.
A lot of them are thin. So it doesn't get diagnosed. And
So
let alone.
are these sleep studies the home sleep study or these in lab sleep studies? And does it matter? Because I wouldn't think a 12-year-old would want to spend, the night in the strange bed in the lab.
It does matter. There's so the insurance is going to require that they do an in-lab sleep study because home sleep study technology actually is significantly inaccurate between home versus in-lab. It's about 15% less accurate with an adult, and with a kid, I don't even know if it has FDA approval to even be used with kids because it's that inaccurate. And there's a number of things, and to put things in perspective, of all the kids I've sent for sleep studies, I've never gotten a case where the family said we ultimately just didn't go. If they didn't go, it was like some sort of family emergency arose or something, but pretty much like the fear that I'm going to make a parent's life a nightmare or a kid's life a nightmare because I'm going to send them to a sleep center, I've realized is non-existent, because the sleep centers that do accept kids, this isn't their first rodeo. They're used to working with kids. They know how to, they know where to put mom and dad in the room. They have a place for them while the kid's in the room. These rooms don't look like doctors' offices. They look like hotel rooms. There's like, so it's a familiar, or it's a comfortable environment. And despite having leads hooked up to them, there's a technician also involved. So if a lead happens to come off, they'll come back in the room and replace it. And there's clearly sleep centers that'll say, we don't take this individual because of their age, or maybe they have an intellectual disability and that's beyond our ability. And then there's others that will be okay with that because they have trained their staff appropriately.
And I'll add to that a clinical pearl. After ordering, I don't know, over 100 sleep studies, 80 for kids, the most upsetting or the thing that really is the most common way to distort the information is actually when I don't help the parents reset their sleep clock first. So if their kid is used to going to bed at 9 or at 2 a.m., then they go to a sleep study, I mean, try getting that kid to go to sleep at 9 p.m. So that's always, I always tell parents that's a mistake on my part. And unfortunately, we're going to have to, analyze this data accordingly or interpret it accordingly. So I think that's something to recall, right, and to remember is that first and foremost, helping families and kids and adults fix their sleep window. So sleep hygiene is still absolutely important. It's not just about airway. It's about quantity and quality and consistency. And so, just like any other kind of exercise or anything else that requires adaptation over time, right? So, so keep that in mind. We talk a lot about airway here, but the basics are still the basics and foundational. Sleep hygiene, sleep hygiene, sleep hygiene, reduce, blue light in the beginning. And for those of you who don't work with kids too often, look up American Academy of Pediatrics based on American Academy of Sleep Medicine's recommendations for how much sleep a certain person at a certain age needs. Surprisingly, for high school students, even 19-year-olds, you're supposed to get like 9 hours of sleep. The younger you get, the more hours you're supposed to get. And the poorer the sleep quality, the more you need. Right? So keep those things in mind. Sleep window needs to be at least attempted to be corrected first.
So how about people with variable schedules and crossing time zones often? REM.
There's a lot of potential scenarios there. If there's one in mind, happy to talk about that. What about people with variable schedules and crossing time zones often? Frankly, treatment potential is inherently going to be limited. You work with a third shift worker, you just have to level with them. I'm sorry, but we're only going to be able to get so far, and with, of course, all the empathy. I mean, sometimes there's oftentimes financial constraints, or not everybody has what's the term, flexibility, or they can't just transfer jobs that easily. But there are some things that could help. Trying to trick the brain using, there's better and better eye masks that completely cover light or block out light. Manta, I started using that one. Looks really cool too. I can't wait to use it on a plane. But
Manta, I gotta look that up.
Yeah, Manta makes some good ones. There's hot versions and cold versions if you want to get into that. But so that could be an opportunity. But from an evolutionary standpoint, and I know for us physicians and other people in the healthcare world, sometimes it's really hard to get away from or stay out of the call schedules and things like that. But just to keep in mind that first and foremost, the sun was on Earth, or was shining on Earth, and the energy came from here. And the pineal gland, if you get more central in structure to the brain, that's the more primitive it is. And everything else that evolved attached to that and set their regulation and their rhythms to the more central structures. So thyroid came later than melatonin. Everything came after the pineal gland. And so that's the central clock resetter. And that responds to the sun. Right. And so, for example, the American Academy of Sleep Medicine is in an outrage right now for the daylight savings time issue, and they feel like it should go the opposite direction, right? I always get confused on how to talk about that quickly, but you know what I mean. So daylight savings time, they're deciding to cancel it. But you can either go in the forward direction or in the backward direction. And their prediction is that going, I think, in the forward direction is not going to be good for mental health. And even in times within a time zone, there's a preponderance of mental health issues towards the west or the east. I forget which, I'm sorry. But the point is that there's a difference in mental health outcomes and health outcomes, depending on whether you are more west or east in that time zone. Because the time is artificial, but the sun don't lie. Yeah.
There's an excellent question here from Shirley. What about TMJ relating to airway issues?
A great one. Dr. Patel, what do you think?
Yeah, there's TMJ. There's a depending on who you ask, you could say there's lines of evidence going both ways when it comes to TMJ and there being a sleep issue. So some will say that TMJ is a result of kind of clenching too much, or maybe you're grinding at night, and that can be a phenomenon of a sleep-related breathing disorder. So you throw that patient on CPAP, all of a sudden their jaw relaxes, because it's thought to be associated to a physiological response to actually the grinding of teeth is meant to open the airway, which is why it's a natural process that occurs in infants. But in terms of we also do in other scenarios, though, like when we're stressed out, we're upset about something, or we have a lot of work, we're just kind of piling through. And then there's features like posture and such. Essentially, the downstream, or you could say airway to jaw effect, is related to not breathing sufficiently, is the suspected belief. And then the jaw to the airway or jaw to the brain issue is this belief that apparently when you clench the jaw, it compresses a nerve that's located in the joint called I believe the sphenopalatine branch, and essentially it sends signaling back, and that's actually what compromises things like your posture and so forth. And so there are specialists that'll work on your breathing simply by actually inserting a splint in your mouth, not anything else. They're not trying to move your jaw necessarily, but with time your bite will gradually adjust. But by just having that splint there, it'll actually release the tension, and also things like your airway will improve and symptoms that are secondary to that. And so it's helpful to know that some of these things do overlap with each other. And that's important because for two things. One, it increases the number of treatment options available, and it also allows us to understand that if we do actually run into a challenge, let's say you have a patient that's not tolerating CPAP, not an uncommon scenario, there's what other options are available. And this is why it's really crucial that as we point out, working with we work with sleep centers in order to get sleep studies completed. We work with ear, nose, throat specialists to have procedures completed. We may work with other individuals who bring other skills to the table, in the case of, let's say, a dentist, if there's TMJ and we think it's associated part of the bigger picture. And so it's crucial to recognize that there are different specialties out there, and they all have, let's say, one part of an understanding or the patient demographic that's being affected by, let's say, this common issue that's at hand, and that they're usually having some sort of difficulty breathing, and that's affecting them in a variety of ways, whether it's their back and their posture for a physical therapist, the TMJ for the dentist, or the brain for a psychiatrist.
I would love to just kind of breeze through the last cases and just kind of point out the things that I think need to be addressed. So yeah, I don't know how many folks in here went through psychiatry training, but I think anybody in the healthcare field has run into dissociative phenomenon in patients, whether it's and frankly, I think at this point I've kind of realized that functional neurologic disorders, dissociative phenomena, conversion disorders, they're all the same thing. It's a network issue up front, and downstream it can look like multiple things. And in this case, this is a 15-year-old female And she presents with these dissociative phenomena that have been going on since she was younger. She kind of found a way to cope with it, but seemed to be getting worse as she's going through puberty. And neuropsychiatric workup from myself, it revealed generalized anxiety disorder and OCD as well, common comorbid factors. Frankly, I'm a little surprised I didn't see some ADHD. It's really common too with sleep apnea. Physical findings, some difficulty with nasal breathing, small oral airway. All my assessments with this family were with at least one of the parents, and very nice family. Typically, our training will say, if you see dissociative phenomena, think trauma, which isn't unreasonable at all. But it doesn't seem to always be the case. So either we can't find it and we keep looking for it, or perhaps there's another avenue here too, looking at the neural substrate and seeing if there's a vulnerability to dissociation, not only that it's learned, possibly that it's acquired, I suppose. So the sleep study revealed total AHI of 8.5, but again, REM AHI 36.5. And I also want to point out that it can be deceptive when you first get the sleep study. REM AHI 36.5 is just how many times during that sleep study the individual had breathing interruptions during REM sleep. I was talking with somebody at Harvard sleep medicine department, and I gave them a sleep study to interpret and got their thoughts. And they said that the REM AHI is actually a little bit misleading because, again, in the sleep lab, although it's the best place for most kids and they know how to work with them, it's still a foreign environment. And most of the time, people in foreign environments have less REM sleep. So if you look at the total AHI, and you actually account for an extra perhaps 5 to 10% REM sleep that they would have at home, their total AHI is actually worse. The standard is that it's worse at home. So REM AHI 36.5, high number, very high number. That's over more than every 2 minutes. Initially, I threw on some Lexapro in order to help with some of the anxiety. And that it didn't decrease the amount of dissociation, but it decreased the kind of amplification of the issue. So you have a dissociation, and then anxiety can kind of take over and go, oh my God, this is an even bigger problem. So the anxiety got a little bit better. So she was a bit more functional, able to go and stay in school a little bit better. And she was also a water polo star and a swimming star. But then we got the sleep study and we started APAP. Went straight for the APAP because they wanted help sooner than later. And lo and behold, over time, the dissociative phenomena got better. It didn't get immediately better. In this case, the dissociative phenomena wasn't conversion disorders, it wasn't functional neurologic problems, but it was depersonalization and derealization. So that means I don't sometimes feel like my body part is my body part. And my brain doesn't say, yes, that car is a car and it's real. I see it, but for some reason, something doesn't happen, something doesn't click for me to believe it. It's for me to feel that it's real. And so those things took time, but lo and behold, and this is a person who had these phenomena since she was like 5 or 6, and just happened to get worse in adolescence. After about 4 to 5 months, now they're rarely happening. We're going down on the Lexapro. She's getting an ENT intervention to see if maybe she won't need APAP forever. And we'll see where it goes from there. But I really wanted to point out this case because we run into this stuff, and it's a big medical mystery, to be frank. I remember being on my neurology rotation as a resident, and it would just take over lunchtime discussions and looking at cases and morning report, because here's this crazy person with legs flailing around or saying things that don't really make sense. And lo and behold, it's not the trauma, it's not the abusive relationship, it's the way that the brain's processing that. So let's go to the next one, and then hopefully we have a minute. I don't know if there's anything. I think the next one's kind of short. Real quick on this one. Autism class 3. Like, you don't need a degree in any kind to know that this is autism walking down the street. Intellectual disability tantrums, great parents, super attentive, and she was in a lot of resources. And so things were kind of okay, but they came to me because they tried all kinds of homeopathic remedies and nothing seemed to work. They were finally ready to do some Western medicine. Initially, she was very small mouth, again, overbite, which it's less about the top and more about the bottom, what that overbite indicates. We should call it an underbite. Maybe. No, I don't know. I don't forget how that goes. Anyway, back, lower jaw, far back, tongue, far back, windpipe, smaller, then you got problems. So we get the sleep study, and at this point, I'm so used to seeing positive sleep studies that I see this 0.8, and I'm like, oh man, I'm gonna have to put my thinking cap on here. Like, what's going on? But then I noticed REM AHI, again, very high. But here's the thing here, the positional component. That's the only thing I really want to point out in this case. Positional component, look at that supine AHI, 20.9. So when she's on her back, something happens and it's terrible. She cannot breathe at all. When she's on her side, doesn't have sleep apnea. So what we did here, initially I ordered some guanfacine just to help with the sleep window. Let's get her to bed, let's establish that. So that actually decreased some of the tantrum frequency. Again, sleep window does a lot, by about 50%. OCD also improved with that. Unusual, it's a little clinical pearl. It's not all about the serotonin system. OCD generally responds to high doses of SSRI. That's kind of the industry standard. That's what we talk about. But I've helped multiple cases with OCD with no SSRIs and just fixing the sleep window. Okay, so what we did was positional sleep training here. I just said, hey mom, you know, you might have to sleep with her, but let's get some pillows together, get the couch cushions, whatever you need to do, and keep her sleeping on her side. When we did that, the tantrums basically completely went away. So
Yeah.
those are the cases. Yeah.
And just to expand on Dr. Shipley's pointed out, you know, a number of cases today have been presented with individuals who have OCD. And, you know, my experience is somewhat similar to his in that I don't necessarily see a complete resolution of OCD, but rather what I do see is that individuals who want to engage in psychotherapies such as exposure and response prevention, which is considered kind of a gold standard for OCD itself, there's this idea that you challenge the obsessions that you have so that way they stop causing you so much distress. Patients have a very hard time engaging in it in the beginning, especially. And when you actually treat their sleep, if there's a sleep problem at hand, what I notice is that they have far more resilience when it comes to tolerating the distress that's bothering them with the obsession. And so when they have to go ahead and challenge those obsessions, they actually move through the therapy much faster. And why? Because they're feeling well rested. And then as they're feeling well rested, they have a greater frustration tolerance. And with a greater frustration tolerance comes greater ease. And especially if they can start getting a couple wins in their back pocket with a couple low hanging fruit or easy obsessions to knock out, then the bigger ones start falling away much faster as well.
Mm-hmm. Mm-hmm. Absolutely.
So would poor sleep also negatively affect motor and verbal tics and Tourette's?
Absolutely. Tics and OCD are, they share a lot of neurology in common, similar network, anterior cingulate, and looking at the prefrontal cortex. And basically, the brain is a thought and movement generator, and the other part of the brain is a thought and movement inhibitor. And it takes a lot of energy to do that. Prefrontal cortex, this giant thing, helps us be human, but what does it really mean to be human? We control our impulses and we can choose to act on something or not act on something. And that's what the prefrontal cortex does. OCD, tics, it's that circuit gone wrong or unchecked, if you will. So you either need a lot of energy or good REM sleep, re-network, and have the energy to, well, kind of grow the prefrontal cortex, learn from your previous day, and things start to get better once you restore the sleep and sleep quality. So for tics, it's actually it's standard of care to use clonidine, so another alpha agonist, alpha 2 agonist, I should say, so it reduces sympathetic output. But not the case for OCD. But maybe Dr. Patel and I need to get some case reports together there. Yeah, so thanks a lot, guys. If any other questions, yeah.
Well, one, I think you're going to say yes to, but does meditation and yoga help?
Yeah.
You already said
Yes.
mindfulness, so I'm gonna guess.
Yeah, I mean, again, it's all part of it, right? Being human is a multifaceted endeavor, and being well is a multifaceted endeavor. So mindfulness helps, and reducing autonomic arousal, I should say sympathetic arousal specifically, prior to bed helps to improve sleep quality. I don't necessarily think that it will cure sleep apnea. I think that's a different facet to sleep, but it can help reduce that tension, perhaps reduce TMJ symptoms, bruxism, and aspects like that. So yeah, it's helpful for recentering. There's a good study done about transcendental meditation, TM, which is you go to a guru and they give you a chant that's yours, uniquely yours. It's kind of like a name in the group. And every morning and every night, around 12 hours apart, you sit, close your eyes, and you repeat that mantra for 20 minutes. And there's something that happens when you help your brain focus on something. It's also a multidimensional approach to stimulate the sensory cortexes, which is most of our brain. I mean, we love to talk about the frontal and prefrontal lobes, but the reality is we are sensing beings first. And so in order to harness the power of our sensory cortexes, transcendental meditation really seems to stimulate that. And so absolutely that's a part, but it doesn't, again, none of these things do the whole picture. Got to look at the whole person. Yeah.
Well, this was lovely. Dr. Weir says it was refreshing to hear from mental health specialists who recognize and work with physical aspects of medicine. There was so much interprofessional here. It was really nice. So don't miss all the thank yous there.